Osteoarthritis of the knee is one of the more common conditions that we see, particularly as the population ages. People often wonder, what is osteoarthritis of the knee? Is it something I catch? Does it spread? Well, most typically it's just a breakdown of your cartilage. It's more of a spectrum than it is a specific point on the line, and it can be present even before you start having symptoms. If you take an x-ray, you would see it, but not necessarily be symptomatic. Most people don't come in for x-ray changes. What they come in for is complaints of pain and dysfunction. So at that point they're symptomatic, and the decision at that point is, what do we need to do about it? Most people have tried the basics, such as NSAIDs, ice, heat, activity modification, and are looking for something a little bit beyond that. We can treat it sometimes with prescription anti-inflammatories, sometimes injections, being either corticosteroid injections or either hyaluronic acid injections can be effective as well. If non-operative treatment consisting of activity modification, therapy, and injections doesn't provide the adequate outcome, and you're still impaired with your activities of daily living and suffering from pain, the next step would be most likely a total knee replacement. In a smaller portion of patients, we can do a partial knee replacement, but more than probably 90% of the people end up needing a total knee replacement rather than a partial knee replacement. People are often intimidated by knee replacement and what it entails and what we're actually doing, size of incisions, tissue sparing, and the like, but the basic idea behind any approach is to replace both the distal femur and proximal tibia with a plastic spacer in between. Essentially what we're doing is we're not making a big cut where we lop off the ends of the bone, but rather resurfacing them by cutting off the edges of the cartilage that's diseased and not providing you with adequate cushion anymore. We have metal caps for the femur and also a metal base plate for the tibia with a plastic liner in between. We're sparing most of your normal anatomy and resurfacing that so that you can get back to your activities with less pain. Post-operatively, people have a lot of questions as to what do they do. We usually send people home several days after surgery with home health, with physical therapy and nursing to help care for them. In other cases, we'll potentially send them to an inpatient rehab facility depending on their level of help available at home. Most people are using a walker or cane for the first 2 to 4 weeks, sometimes getting off of it by 2 to 4 weeks, and then keeping with their progression to outpatient therapy around the 4-week mark, returning to driving somewhere between 4 and 6 weeks, and doing well by the 6 to 8 week mark, but they continue to improve up to 6 months afterwards. I would say by and large most people are very happy with the results, and that the most common sentiment is they wish they had done it sooner.